about the renin angiotensin aldosterone system. And really, we're going to focus on the drugs, ACE inhibitors and angiotensin receptor blockers, but we're going to review it real quick. You can look back at my blood pressure lectures where I'll go over the whole system and really discuss in more detail how it affects your blood pressure. So this system maintains your blood volume and helps maintain your blood pressure, which is a good thing in a normotensive patient. Hypertensive patients, if this is overactive, or we can inhibit this, which we're going to talk about, to lower blood pressure. So it all starts in the kidneys, right? The kidneys are a player here. The liver, the lungs, and the brain, the hypothalamus, the pituitary gland, and the adrenal gland. There's a lot of stuff going on, but it's okay. So how it starts in the kidneys are underperfused or feel they're not being perfused enough. And that's really measured by special cells, by flow going through the nephron and through the kidney. So if they say, hey, flow is low, we need to increase blood pressure, can try to push more blood towards the kidneys. That's kind of what the thinking is, right? And renin's an enzyme. So it's going to convert this protein from the liver, it's inactive protein called angiotensinogen, right? Ogens are inactive proteins. Think fibrinogen, plasminogen, pepsinogen. And it's going to activate it into angiotensin 1. Now, there's a second step. Angiotensin 1 needs converted to angiotensin 2, and we need another enzyme that comes from the lungs called ACE, angiotensin converting enzyme, ACE. Okay, now we have angiotensin 2. Angiotensin 2 has all the effects in the renin angiotensin aldosterone system. There's three main effects you need to know. In no particular order, they're numbered here 1, 2, 3. I don't know if one's more significant than the other. Not really, right? So first we'll talk about this. It's going to affect arteries and it's going to lead to vasoconstriction. So vasoconstriction is going to increase peripheral resistance, which we call TPR, total peripheral resistance. That's going to take our blood vessels and just constrict them down, right? So whatever volume of blood we have, we're just compressing a little bit. That's going to increase your blood pressure. The other two things that are going to happen, it's going to cause release of two hormones. So one hormone, it's made in the hypothalamus, stored in the posterior pituitary, and released from there is anti-diuretic hormone. The other name you need to know for that is vasopressin. So anti-diuretic hormone, so it's the opposite of a diuretic. So go all the way, released from the posterior pituitary all the way to the kidneys. It's going to cause water retention. So you're going to reabsorb water at the collecting duct of the nephron. It's going to increase your blood volume, which can increase your blood pressure. Now, a lot of this is controlled by special osmoreceptors in the hypothalamus measuring your osmolarity. So osmolarity goes up, usually because you're dehydrated, your blood becomes more concentrated. You make more ADH, you hold on to more water. So that's one of the stimuli we have affecting that. It controls blood osmolarity, but angiotensin 2 will cause a little more release of that vasopressin. Anyway, the third thing, aldosterone release. Aldosterone gets released from the adrenal cortex. There's three layers of the cortex: glomerulosa, fasciculata, reticularis. This gets released from the outermost layer of the adrenal cortex, the zona glomerulosa. Aldosterone is a steroid hormone. It's going to act on the kidneys just below the adrenal glands where it gets released. Three effects. So sodium reabsorption, so you're going to retain sodium. Water is going to follow it, so we get water reabsorption. So we're going to retain water and sodium. It's going to increase blood volume, increase blood pressure. That's what this is doing, okay? And the last thing, increase sodium or potassium secretion. You're going to pee out more potassium, right? You're urinating out more potassium and getting rid of potassium. That's going to be an important point here in a second. Okay, so the two drug classes we're talking about are ACE inhibitors. So ACE, angiotensin converting enzyme inhibitors. These are the pril drugs that end in PRIL. So prils, enalapril, lisinopril, ramipril, all the pril drugs, whatever pril. ARBs, angiotensin receptor blockers. These are the sartan drugs. So SARTAN. So sartan, losartan, valsartan, telmisartan, whatever sartan. So where are they going to work here? So ACE inhibitors are going to inhibit ACE. So if we inhibit ACE to some degree, we'll have less conversion of angiotensin 1 to angiotensin 2. Less angiotensin 2 will have less of these effects. So what does that mean? Lower release of vasopressin, less vasoconstriction, less aldosterone release. That makes sense. ARBs are going to work here. They'll work more downstream. They came out after ACE inhibitors, so they're made later. And said, hey, let's work on this more downstream, and they're going to block receptors for angiotensin 2, hence angiotensin receptor blockers, and they reduce the effects of angiotensin 2. So effectively, both drugs are having the same effect. They're just working in a different place. Now, adverse effects, things you absolutely have to know. For both of these, not common, but not uncommon, right? I've seen it multiple times. angioedema. So you can be an ACE inhibitor, more likely an ACE inhibitor because they increase something called bradykinin. Even an ARB, swelling of the throat, the lips, the mouth, right? Usually happens with the ACE inhibitor. You can be on it for like 10 years, never a problem. One day everything swells up. You gotta be on steroids and your airway's closing, it's a mess, right? And usually you go into ARB and it's okay, right? But it could happen with an ARB, but more of this. Other things, with ACE inhibitors especially, dry, hacking cough. Now, this will be a test question and they'll say, oh, productive cough. No productive cough, dry, hacking cough with ACE inhibitors. That's always a test question because they'll trick you with saying, oh, productive cough. Now, both of these things, that's why I brought up this thing about potassium secretion. If you have less aldosterone, well, you're going to pee out less potassium, so potassium levels could go higher. You could develop mild hyperkalemia, so high potassium, and may not be so severe, but think about if there's other things going on, other drugs that retain potassium, like a potassium-sparing diuretic, which might not make sense, or something like someone's taking a really high potassium diet, they're eating tons of bananas and greens and fruits and all these things, which is great for you, or sodium substitutes. So if someone has hypertension, they would say, hey, I don't want to take the salt. They use a sodium substitute. Guess what? So most salt substitutes, instead of sodium chloride, they're potassium chloride. If they're dumping a ton of that in their food, you got to be a little careful, right, with their potassium intake and just check and make sure they're okay. So hyperkalemia with both, and if it does get real bad, hyperkalemia can lead to severe arrhythmias, like fatal arrhythmias, like ventricular fibrillation. So that is something you always have to worry about, but it's not super common. The angioedema thing, you always have to keep that in the back of your mind because if their airway closes all the way, right, it could even be fatal if it gets that bad. And the dry hacking cough with ACE inhibitors. And always with blood pressure meds, one of the side effects you always worry about is, well, hypotension, the opposite of what it does, right? It's treating hypertension. If it treats the hypertension too much, well, then you get hypotension. And the last thing, it's actually a good thing, it's not an adverse effect by ACE inhibitors and ARBs, is they're renal protective, right? They're protective of your kidneys, which is great in patients who have hypertension and patients who have diabetes mellitus, because guess what the two leading causes of chronic kidney disease are? Uncontrolled hypertension and diabetes mellitus. Like 70 to 80% of chronic kidney disease is caused by those two conditions. And imagine if you have high blood pressure and you're diabetic, well, that puts you at even more risk. So you got to keep your blood sugars under control, but you want to keep your blood pressure under control as well. And these drugs can be renal protective to some extent. They'll protect the nephrons that you might have left if you already have damage. So takeaway points, they're going to lower blood pressure by inhibiting this renin, angiotensin, aldosterone system to some extent. They're going to increase potassium potentially, so you got to watch out for that. Angioedema could occur anytime, and especially the dry hacking cough with ACE inhibitors. And if you got that, you're in fantastic shape and you understand this stuff.